Thank you, Dr. Suzanne. Thank you. Very
Welcome.
impressive
Welcome.
data, mashallah.
Thank you. Thank you.
And nice review, to the
Thank you.
point, mentioning all the data, OPERA 1 and 2, and all the side effect, the bruises and others. I will ask Dr. Areen to join us. Areen, you can turn on your camera. I have plenty of questions, Areen, here that has came through the our participant. I'm so glad that we have this big number of people with us. So let me to start with something. Time is brain. That is not just for the stroke, Areen and Suzanne. It's also with the MS, right? Areen, do you agree?
I totally agree.
Okay, and the stroke, it's minutes, but with the MS, it's months or year. So delay in treatment, delay in controlling the disease activity, as Suzanne said, is very important to prevent the disability. The last statement that you mentioned, Suzanne, 1 attack in 20 years.
Yes.
Areen, this was a dream, حلم, huh? When you were in the US to reach this point. It's like a cure.
Absolutely. If we can reach that, that would be great.
Yeah. Okay. So before we go to the questions, I prepare something here, Irene. If someone will ask Suhail, what will make the decision of your patients to choose the right treatment for the MS? I put few points here, and I would like Irene and Suzanne to share me. So if I will choose a drug for my patient, I said it should be with less number of relapse or no relapses. I'm looking for a drug which is need almost zero. I'm looking for a drug which can spare the brain volume on a long term, no disability on a long term, easy to use, availability of drugs, less side effects or adverse event, and price, very important. Any other points that will cross your mind, Irene and Suzanne, with any drugs that you are choosing for your patients?
I think you summarized the points that we are looking at when we try to choose for our MS patients.
Fertility, I didn't mention fertility. Maybe I will add there, Suzanne.
Yes.
Agree?
Yeah. Yes, 100%. So this is actually the criteria that we look for when we choose a medications for our patients, depending, of course, on the patient's criteria themselves. And as you mentioned, that if females are their productive age, we have to choose a medicine that will be compatible, or at least they can give a chance for pregnancy without compromising their dreams of being mothers. So this most of the criteria that, as you mentioned, how we choose our medications for our patients. We need something that's effective, that is safe. A patient that we see today, we need to see the same patients or in better shape 20 years later.
Agree. First questions, Irene. If a patient gets attacks on or relapses while he's on a highly efficacious drugs, how you can deal with these patients? So it's mean maybe a severe form of MS.
Yeah, I mean, one of the things is to be sure that they are taking their medication appropriately. The second thing would be if that particular patient had attacks or relapses on high efficacy drugs, we can consider switching sometimes between these drugs because they have different mechanisms of action, at least some of them. And we can escalate also the therapies for even higher effective drugs, although some may be off label, or we can go to hematopoietic stem cell, although this is also only advised to be done under research programs. But this is what we do for high efficacy drugs who are failing.
Okay. Dr. Suzanne, how many weeks are between the Ocrevus infusion? You mentioned this, just if you can repeat it.
The Ocrevus is given in infusion every 5 or 6 months, 24 weeks. The first infusion will be a paired infusion given with 300 milligram. 14 days later, we will take the second dose. This is only for the first infusion. Yeah, each infusion afterwards will be a 600 milligram taken in, after 24 weeks, 24 weeks afterwards.
Good, good. There's a question from Dr. Muhammad Salim. Good evening. Thank you for this presentation. Can you tell us about a secondary MS, a secondary progression, it seems, with the EDDS above 6? Is there any new medication, and how about Ocrevus in these patients, Areen?
You know, this is a very good question. In these patient cases, we should sometimes stick to the label. So ocrelizumab is actually approved for relapsing forms of MS, and also for and for primary progressive MS patients. So if a patient has secondary progressive MS with relapses, this may be potentially a patient that you can use ocrelizumab. However, if they have secondary progression without relapses, so the benefit of ocrelizumab is going to be very limited and probably should not be used in this particular patient. There are some medications approved also for secondary progressive MS, but also these medications are approved for those who have relapses.
Like
supinimoid and RPC 1063. I forgot the brand name for it. Yes.
Okay. Suzanne, there's a question regarding hepatitis B virus with Ocrevus. Any contraindication with that, and why?
So actually, for patients, before we start the patients on Ocrevus, we have to do a panel of tests to make sure that the patient is free of infection or dormant infection, like hepatitis and tuberculosis as well. Patients have to receive the vaccine before starting this, because after receiving the dose, there will be some suppression of the immunity. So this can flare up all the non-active viruses in the body or active bacteria like tuberculosis. So patients have to receive the vaccine before we start the medications, and we should give a period for 4 weeks to 6 weeks before initiating the Ocrevus therapy. It's also true for zoster, for varicella zoster. So it has also to be screened before the starting medications.
This question for both of you. You remember that we used to have in neurology with the epilepsy drugs, anti-epileptic, the old and new version. Then we had with the anticoagulation for stroke, NUAC, which is novel new oral anticoagulant. Okay, then that has been vanished. Do you think that we are reaching a point where we should stop saying all the new, or aggressive, non-aggressive, or escalating, non-escalating, because all these medicines are working on the same thing? I understand in the US or Europe, when they're using the class 1, class 2, class 3, my belief is this is based on the safety, but the most important part is on the financial, on the cost of these medication, Areen. Are we still teaching our resident, our student, our patients that there's old medicine and new medicine? There's safety medicine, non-safe medicine, because they are new. What do you think about this? For example, a medication like Fingo has been in the market almost 15 years now, but still some people are considering this is a new medication. The same thing with the other oral treatment or IV. Tizapri has been almost 15 years, also 11 years now. Suzanne, Areen, both.
Suzanne, I'll take this one. I'll give my opinion. Based on what we have now, I would say that we probably are still in a phase that we need to define the medicines as highly effective or higher effective medication than others. Probably avoiding the term old or new is okay, but probably we should still mention highly effective drug, and probably we should mention also about safety about these drugs.
Suzanne, before that, sorry, Areen, when you say highly effective, so why, Dr. Areen, you are giving me a low effective drugs and sparing the highly effective drugs? You are not a good doctor giving me the low effective and keeping the high effective to other patients.
Yeah, I mean, it depends on the patient situation. For example, you have patients who may be pregnant, and so you have to tailor the treatment by using maybe some of these approved drugs in pregnancy, like some of the interferons, which are considered less effective in the best environment than these B-cell therapies or adhesion molecular therapies. So for that particular patient under the circumstances, it would be okay to use less effective drug. Or if a patient develop, become immune compromised on the B-cell therapies, or for example, cladribine or alemtuzumab, then maybe we need to go to less effective but more safer medication in these particular scenarios. So I think we still should use also high efficacy drugs, but knowing about the safety profile of these drugs, and we should keep them hand in hand when we prescribe for patients. So
agree. مشكور. Irene, I didn't mean when I said bad doctor, you are a good doctor, but bad doctor, and when the patients will say it, Habibi.
It's okay, no problem. No problem.
Suzanne, تفضلي.
I would comment on this old medicine and new medicine for multiple sclerosis. We still use all the medicines, and the guidelines still talking about first line therapy, second line, third and fourth line therapy. In multiple sclerosis, our target always is to have a personalized treatment for the patients, depending on the criteria of the patient themselves, the preference of the patient. I'll give you an example. As Dr. Ali mentioned, that we have to use a high efficacy medications when the disease having a high activity as well. I have a patient with a very high active disease, very high loading, lesion load in her brain, frequent relapses. She wanted to get pregnant because she was newly married. And she opted and she elected to use interferon beta 1A for her treatment. Although that we advised to control her disease in a better way, to preserve her functionality, we need to use a higher medications. Pregnancy can come later, but her preference was pregnancy over her disease course. So still we are using all the drugs at the same way, depending on the disease course, depending on the patient's preference, depending on safety profile, of course, and the availability and affordability as well.
Question in the same area from Dr. As-Safad. What are the accepted combination of treatment for a female MS patient who's looking to be pregnant? And if she became pregnant, do we have to change these medicine? Dr. Suzanne.
For patients who want to become pregnant, I just gave an example for this one. Of course, we have the medicine that have been approved to be used during pregnancy, but still we have to consider the activity of her disease at least 1 year before getting pregnant. If she has a stable disease course in 1 year before, then the patient can safely go into pregnancy or choose to get pregnant without having any medications. In case that her disease is still active and she still wants to get pregnant, we have some drugs like natalizumab still can be used during pregnancy depending on her disease activity. Interferon beta 1A, glatiramer acetate, both are safe during pregnancy, especially glatiramer acetate, which has been categorized according to the FDA as category B during pregnancy.
Agree. Irene, do you want to add something here?
No, I agree. I agree.
Okay, so another questions which I have here. Adverse effect of Ocrevus from your experience, Suzanne?
Adverse events, not serious events, usually occurs like infusion-related reactions, and as we mentioned that it occurred mostly during the first infusion, the first paired infusion. So now I think Roche has also implemented the home infusion for patients, especially during this COVID period when patients cannot come to hospitals. But still, for the first doses, patients has to be in the hospital. We cannot give them at home because we need to observe the patients during their infusions, the first and second infusion, which is the first dose that is divided into 300 milligram, 14 days later, another 300 milligram. If infusion-related reaction not occur during this period, it's less likely to occur afterwards. Other effects, very, very minor reported during the study, like I said, the upper respiratory tract infection, but it was also minor, no serious, and no death, no PML.
Thank you very much, Dr. Suzanne. This is from Dr. Walid At-Tantawi. What's your opinion in decreasing the maintenance dose of Ocrevus to only 300 or increase the dose interval from 24 to 36 weeks? Dr. Walid is looking to build his own study here.
I would answer this one according to the label, the FDA approval. So FDA approved Ocrevus to be used 600 milligram doses every 20 to 24 weeks. But increasing the interval or reducing the dose, I will leave it to Roche if they have any experience or any studies done on a smaller doses or higher gaps. I have no idea regarding that.
Okay. Dr. Areen, these are questions from Dr. Al-Hammouri. If a patient is presented with only optic neuritis, which is the CIS, and the MRI is in a favor of MS, is this an indication to start this patient on Ocrevus?
That's a very good question. So patients who have optic neuritis and they had MRI lesions or they don't have MRI lesions. If they don't have MRI lesions, then there is no data to start these patients on immunomodulating agents, because in the clinical trials, they enrolled patients who had at least 2 or 3 typical demyelinating lesions in addition to their clinical attack, whether it was optic neuritis or transverse myelitis or brainstem syndrome. Now, if the patient does have optic neuritis and they have lesions that are disseminated in space, and maybe there is lesions in the spinal cord, this is a very good question, because it takes us to the Magnimus data and whether to consider optic neuritis as part of the first demyelinating syndromes. This particular patient, if they have lesions and they have oligoclonal bands in their spinal fluid, there is no reason why not to start them on ocrelizumab or other approved therapies for clinically isolated syndrome.
So the question was, I believe he meant patients presented with optic neuritis, MRI in a favor of MS, which means more than 3 lesions, most likely. Do you consider this patient to go directly to Ocrevus, or you would like to try the first line medicine before going to Ocrevus?
I think both of them are approved for clinically isolated syndromes. So the interferons, even glatiramer acetate in their PRECISE trial, the ETOMs, the CHAMPS trials using interferons, and also many of the new medication are approved for clinically isolated syndrome. So, I have to put many factors, patient safety first, more information. And then if I think if everything allows me to use ocrelizumab, then I will use ocrelizumab.
Clear. Let me to ask the questions, the same question in another way. What will make you not use Ocrevus on these patients?
Very good. Let's say the patient has a contraindication. That would be one reason. Okay. Let's say the patient has active infection, okay, whether it is hepatitis or herpes, or patient is immune compromised, or a patient who tells me, I want to take the COVID vaccine today. Or next week. Probably I will not choose ocrelizumab at this time, because I probably would delay the treatment or choose other therapy that may not be contraindicated with the vaccine. I think if the patient is planning to be pregnant in the next few months, I probably will go to other therapies. I think if the patient does have optic neuritis, but I believe they have neuromyelitis optica rather than MS, I will not use ocrelizumab. So these are probably what comes to my mind now.
Suzanne, anything which will make you not Ocrevus, which MS patients will not be a candidate?
As Dr. Ali, I agree with all Dr. Ali mentioned now, but if it is CIS, like a CIS, so definitely I'm not going to start Ocrevus on such patients. But even though that with a positive oligoclonal bands in their CSF, they have a high probability of conversion to clinical definite MS, but still a CIS would not be an indication to start Ocrevus, because Ocrevus is approved for relapsing multiple sclerosis.
Agree.
Unless it's a CIS. If an MRI is otherwise is consistent, as Dr. Arine just mentioned that, according to Magnus study or Agnes consensus, if the MRI alone is consistent with a clinical definite MS or a multiple sclerosis, relapsing multiple sclerosis, as we can tell now from one MRI, then it could be an option to start on Ocrevus as well.
Okay, we have.
I just have a point.
Oh,
I agree with Suzanne, but maybe we are mixing between the package inserts. I think the FDA approved ocrelizumab
yeah, yes,
2019 for CIS.
yes.
Okay.
CIS,
Yeah,
okay.
CIS is approved. It's mainly CIS relapse remitting, which has been approved. A question here, Irene, before we ended, the last two questions. If a female patient's first attack was transverse myelitis and the MRI brain showed multiple white matter disease lesion in a favor of MS, can I start this patient on Ocrevus? CIS, transverse myelitis with the brain. Is there, do you consider the first options treatment there?
Yes.
First, we have to rule out NMO.
Yeah.
If you confirm the patient has MS and you rule out, excellent, Suzanne, thank you. Yeah, it could be an option, absolutely.
Okay. How about COVID and Ocrevus, Suzanne, vaccine infected patients? Any insight about this?
This is a very good question. In fact, because now we are dealing with patients who are receiving Ocrevus during this pandemic. From the study that we have, from the data that we have so far, patients who received CD20 depressant like Ocrevus, rituximab also, they can have a little more severe disease than other people with multiple sclerosis. We know all MS patients, they can have a similar severity of the disease as other population. But for CD20 population, depleted cells population, may they have a little severe disease. If the patient did not receive their doses recently, and if their lymphocyte count is normal, or B20 is normal, so there is no contraindication to receive their vaccine, provided that this patient has not received their dose recently. I think 3 months in between, if I'm not wrong, so they should not receive COVID vaccine.
Clear. At the end, just I receive a chat from someone called As-Sahili. We answered your questions at the beginning very early. So at the end, I would like to thank Dr. Arine Sayed and Dr. Suzanne Nouri to be with us tonight. Thanks for Roche for sponsoring this meeting, and wish you a great day, inshallah, and hope to see you soon on another session, inshallah. Thank you, Arine. Thank you, Suzanne. Thanks for everyone for attending this session.
Thank you so much. Thank you.
Thank you,
Have a good
everyone.
night.
Thank you.
شكرا.
Bye.
مع السلامة.
عرين بعد في العيادة ها؟
نعم.
شفتي قلت لك سوزان أنا عرين بعد في العيادة.
Always there.
Always there.
Always. مع السلامة.
يلا السلام عليكم.
السلام عليكم. يلا باي باي.
مع السلامة.
السلام.